everybody. So we're now just going to go through the feedback to all of the sessions. So the way I'd like to do this is I'm very mindful of time. We've still got another case study to do. I am going to go through all of the answers from my perspective. For the cases that you have been doing in your breakout rooms, you can then compare notes based on what I've said, effectively mark your own work. Please make notes on the one that you haven't done. I will make it clear where the information is if you don't manage to write it all down during the course of the session. So we're going to start with case study 1. So I'm not going to go through all of the information, but this is a gentleman that's got advanced prostate cancer, and he'd been started on a LHRH analogue known as goserelin. And the first question you're asked is what side effects you should tell Mr. PC about with respect to this treatment. If you look at resource pack 1, so the pack that was posted on Moodle for case study 1, all of the answers are in there. The main ones to think about are fatigue, urinary and sexual dysfunction, loss of fertility, hot flushes, excessive sweating, gynecomastia, breast tenderness, injection site reaction, so this is a subcutaneous preparation, hence the injection site reaction, and osteoporosis. They are all in the LCA guidelines that were posted up on Moodle. This information can also be found in the BNF and the SPC for goserelin preparation. If anyone had any questions during the course of the feedback, please put them in the chat and I will take them as we go. I will make sure, as I say, that I'm giving you the answers to, or where to find the information if it's not the full answer. So second question was, what can you suggest to manage some of those side effects? In this case, that's also in the resource pack that was supplied for case study 1. So for example, you can do pelvic floor exercises for bladder retraining. We can use antimuscarinics if necessary to help with the urinary dysfunction. For the hot flushes, we can, as an unlicensed treatment, use medroxyprogesterone, and that would be 20 milligrams once a day for 10 weeks. Usually, the erectile dysfunction has to be referred to a specialist service for PDE5 inhibitors. There's also calcium and vitamin D for the osteoporosis possible side effects. We don't tend to start a bisphosphonate unless the osteoporosis is actually present, but we can use calcium and vitamin D if we think it could happen. So we just wait for it to occur before the bisphosphonate start. And then it's also recommended that they have regular resistant exercise for fatigue. Acupuncture, complementary therapies may also be used. The medroxyprogesterone is actually recommended by NICE if it is something that we find that there's not been any success in treating the hot flushes in any other way, then the unlicensed treatment would be acceptable. So moving on to question 3, at this point the Nemostella formula is the way that we use to calculate body surface area on the lecture slide. You should have come out with a body surface area of 1.82 meters squared, so that's 1.82. You'll remember in the lecture I said we typically round to 2 decimal places in practice, so 1.82. The formula, if you do have a question on this in the exam, will be given to you. So the dose of docetaxel in prostate cancer is 75 milligrams per meter squared. For this surface area, that gives 136.42, which we would round to 136. So in this case, we would round it to the nearest whole number, which was 136 milligrams. It then goes on to question 4, that as part of the regimen, what additional treatment should he receive and why? This is all in the resource pack. So under the guidelines you see for docetaxel, it mentions dexamethasone. The dexamethasone is given as an 8 milligram oral dose, 12, 3 and 1 hour before the docetaxel infusion. So 3 doses before the docetaxel infusion, 12 hours before, 3 hours before, and 1 hour before. The purpose of the dexamethasone is to reduce the incidence and severity of fluid retention and also minimise the probability of a hypersensitivity reaction. We would then expect, due to the high dose of the dexamethasone, that there would be use of a PPI, that might also increase the risk of fractures, so that has to be something that we need to consider in the longer term. One of the things to think about, you'll see in the LCA guidelines for the docetaxel, In prostate cancer, we typically use prednisolone on a continuous basis, usually 5 milligrams twice a day orally, alongside the docetaxel throughout treatment. If you are giving dexamethasone as a pre-treatment for the docetaxel, you are giving 2 steroids at the same time. So what that usually means is, in practice, the prednisolone is suspended for the day or possibly 2 days where you've got the dexamethasone. So, for example, if the docetaxel appointment is 9 a.m. in the morning, then the prednisolone would be suspended for that day, and they would probably miss the day before as well, because the 12-hour pre-dose would have been taken the night before. So I hope that makes sense. Moving on to question 5, what should be monitored every cycle and during treatment with docetaxel? This is all in the guidelines that was supplied for the case study. So full blood count, liver function, UNEs. We do need to keep an eye on the PSA, and that's about the efficacy. So the prostate-specific antigen tells us whether what we're doing actually works, and we would be looking at that as a monitor of how well the person is responding to treatment, how well we're actually treating the prostate cancer. We need to consider the clinical toxicity. So I've already mentioned some things like fluid retention, hypersensitivity. Does the patient have any side effects that could occur with the treatment? Docetaxel is a vesicant, so we need to be very mindful that there's a risk of extravasation to make sure that that doesn't occur with treatment. And as I said, because of the fluid retention, that's something that we need to monitor very, very carefully. So hopefully that will make sense so far. Please ask me anything you're not sure about in the chat, and I will go back through it. And that brings me on to the last question, question 6 for case 1, which is basically where the patient unfortunately developed grade 1 PPE. How did this impact on his next cycle, and what lifestyle advice is there? Now, there are various different websites for this. The brilliant one for this is the cancer.net website, and they have a great list of interventions which are what we use in practice to help patients with PPE. So, first of all, the thing to mention is that hand-foot syndrome is usually worse in the first 6 weeks of treatment, so that's something that we need to be mindful of. In chemotherapy, it can actually take place 2 or 3 months later, so it's not something that often happens straight away. There's a few things that are immediate things that the patient can do. So limit the use of hot water on the hands and feet. Take cool baths or showers, and pat the skin dry carefully rather than rub it quite aggressively after they've had a shower or bath. Cool the hands and feet. The ice packs are brilliant. Cold running water. Think about how you would manage a burn. Similar. That's what we would do with PPE. But what we need to be very careful of, and probably you're all aware of this as well, if you've had an inflammation or a burn and you get ice or an ice pack out of the fridge, you never put it directly on the skin. Always wrap it in a towel. That is critical, because the ice itself can actually make the PPE worse if there's not a barrier between the ice and the skin. So avoid sources of heat. So that's things like saunas, for example, hot tubs, things that would warm up the hands and feet, make the symptoms worse. Avoid activities that cause force or rubbing during the first 6 weeks of treatment. So, for example, jogging, anything like that. Or in particular, if you have to hold something like a racket or run around on your feet, can make the symptoms worse. Avoid contact with harsh chemicals. So, classic with this is, if, for instance, they want to do the washing up, they'd have to be thinking about what temperature the water is, and they would have to wear washing up gloves so that they're not in contact with the detergent. It does, however, say that you should try and avoid using gloves without a liner in it, and the reason being, you don't want the rubber to come into direct contact with the skin either. The rubber itself can actually be an irritant for PPE. Avoid using tools or household items that require pressing your hand against a hard surface. A classic is something like a screwdriver. If you think about how hard you have and the force it can take to undo a screw or put a screw in, that sort of thing they need to be very careful of. They can use skincare creams, and they need to gently apply them. Anything that has a moisturising effect, but you need to avoid anything that's got perfume in it. The perfume itself can be irritant, so you need a very, very mild, and particularly anything that's hypoallergenic would be brilliant. That sort of thing would be a very useful emollient to use on the hands or feet. Loose fitting and well ventilated shoes and clothes. Try not to walk barefoot. If there are any areas on the particular, like calluses or any rough areas of the skin, it's recommended seeing a podiatrist because that can make the PPE even more uncomfortable. We sometimes use ice packs actually during chemotherapy. It depends on quite how bad the PPE is and whether the actual administration at the time of chemotherapy is a trigger for the symptom. So there's lots and lots of things. The cancer.net website lists absolutely everything I've just told you. So for those of you who haven't quite managed to note everything down, that's where you can find all of that information. So that brings us to the end of case study 1. I will move on to small cell lung cancer treatment. The first question you're asking this is to calculate the dose of hydroxyurethanin. In the resource pack for case study 2, you have the CAB protocol and it tells you that the doxorubicin dose is 50 milligrams, 50 milligrams per meter squared. Using the Mostella formula, so the same way that we did that in case study 1 from the lecture slide. Again, a reminder, if there is an exam question on it, you will get the formula. The Mostella BSA comes out as 1.52. Remember, we use 2 decimal places when we calculate the body surface area. That means the doxorubicin dose, so the 50 milligrams per meter squared, comes out as 76 milligrams. That was all from the regimen as posted in the resources pack. So we move on to thinking about cumulative doxorubicin doses. So we typically give 4 to 6 cycles of small cell lung cancer treatment with CAB. How many cycles could she have without breaching her lifetime cumulative allowance, and why does that allowance exist? Well, this is where there's a bit of debate. So either of these answers is acceptable. In the guideline, you will see that it says 550 milligrams per meter squared as the lifetime cumulative dose, which for her body surface area of 1.52 means she could have 836 milligrams of doxorubicin in her lifetime. 836 divided by the dose per cycle, which is 76, means she could have 11 cycles. In practice, we try to stop a bit earlier than that because there is some degree of evidence that suggests that actually after 450 milligrams per meter squared, there is actually a significant change in the risk. So if we use the lower threshold of a lifetime cumulative allowance of 450 milligrams per meter squared, we would only be able to give her 9 cycles. And so either of those answers are correct. That it would be 9 or 11 cycles would be her maximum, depending on which lifetime allowance you use. So moving on to question 3, please remember to ask me anything that you're not sure about in the chat. I'll keep an eye on that as we go. It says, which of the drugs in CAB might require a baseline MUGA, and what is it? So this information is readily available in the regimen guideline. If you get stuck, you will find this information on Google as well. So what a MUGA scan is the use of a radioactive isotope that gets injected into the bloodstream, and it enables us to see and monitor the function of the heart using gamma cameras. And what we typically do is we're watching the heart function, but we're also running an ECG at the same time. And what it gives us is a figure for what is known as the ejection fraction. And that is the percentage of the total capacity of the left ventricle that is ejected in one heartbeat or one contraction of the left ventricle. Now, you would have thought the higher the better, which is exactly right. The better the function of the heart, the greater the percentage of blood in the left ventricle would come out in one push. So that's what we measure, the left ventricular ejection fraction, and that is what it is. The reason that we do this scan is because doxorubicin as an anthracycline is cardiotoxic. We've already talked about the lifetime cumulative allowance, and it is the cardiotoxicity that is the reason for that allowance. There is a post-work question here, which is what are the other monitoring parameters for this regimen and why are they important? All of that information is readily available in the regimen. So moving on to question 4, in her second cycle of treatment, the skin around the line starts to become irritated and warm. What do we think is the cause of this, and what would the next step be? There are 2 possible causes of this. So when this happens, the immediate thing we would think is this extravasation? Do we have a drug that is likely to cause it? We just look at all of the drugs. There's 3 different drugs that are involved in CAB and identify the risk. we can identify the risk, for example, with the NHS England guideline that I refer to on the lecture slide. It will give you very clearly the category for every drug that we commonly use in terms of the probability of them being a beta-second. In this case, doxorubicin and vincristine, which are two of the three drugs in CAB, both are known beta-second. So one or other or both are the most likely cause of this reaction. There are local guidelines in most trusts, but we broadly stick by the NHS England guidelines as to how we would manage any extravasation. So you need to be able to recognise the signs and symptoms and be able to talk through the management options for it. As I said, that is why the NHS England guidelines are made available to you in the lecture. So signs and symptoms are severe stinging or burning pain. That is a common symptom, but it's not always present, and it can be hours to minutes or hours after the infusion. It will eventually go away. What I've seen most commonly is actually pain that occurs during the course of the drug administration, where you have to stop it immediately. The redness isn't actually there straight away. You'll more likely see a blanch, is the kind of a whitening around where the cannula, so the injection going in, and that then starts to become inflamed before the redness sits in. The redness then appears around wherever the line has gone in, and the swelling then starts to come. It may not be immediate, but it's also not always easy to identify, but ultimately you get a very localized reaction. You can have what we call inability for blood return. Now, what that means is, if you have the cannula in situ and you disconnect whatever syringe or pump is delivering the chemotherapy, you will still have a needle in that vein. If you then went to get a blood tube, so you were trying to then draw blood back out of that vein, you can struggle to get it back. So we call it a difficulty in getting blood return. So basically, if you went to go and take a blood sample from the exact line that drug's just gone through, you probably can't get the blood back out. You sometimes see, and this is typically the first warning sign for a nurse, is that all of a sudden there is a change in the ability of the drug to run through the line. So what can happen is that for whatever reason, if it's a pump, for instance, they're often connected to an electronic device which ensures that it runs at a constant rate. It starts beeping because the drug stops going into the vein. Or if the nurse is manually giving it via syringe, they get to a point where they can't actually push the plunger down anymore because there's resistance. That's typically the first sign that you've got an extravasation reaction, because the reaction stops the drug being able to go in, which is actually quite a good thing. It minimises how much is going into the system. So if a patient presents with blistering, erythema, swelling or pain up to a week after chemotherapy containing a vesicant, then we still suspect extravasation. So even if it's up to a week afterwards, we still have to rule that out. There are local guidelines, but the basic principles are in the NHS England guideline, and there's a lovely flowchart which we call management of extravasation via peripheral cannula, and it lists all the different steps. I will not go through this in detail, it's quite a long flowchart. It is in the guideline that I made available in the lecture. So if anyone had any problem finding it, please let me know, but it is all there for you to look at in your own time. So we're moving on to question 5. That in this case, the lady is lucky and there's no long-term damage. She comes in for her 4th cycle of chemo and she has some tingling and pain in her fingers and her feet. She said it's affecting her ability to carry out some more fiddly tasks, for example, getting change out of her purse or picking up more items. So the question is, what is she showing signs of, and does it impact on her next cycle of treatment? So I had some good questions when I went round some of the groups who were working through this. At what point do you say that this is actually affecting this lady's quality of life, her ability to carry out daily tasks? Well, this is a classic sign of neurotoxicity and most likely due to the vincristine. So she's developed neuropathy, and this is what you're seeing or being described is neuropathic pain. CAB, as I mentioned, is a typical second-line treatment for small cell lung cancer. Unfortunately, the cure rate of small cell lung cancer is very, very low. So what is most likely to happen with this lady is that we are aiming for disease control, symptom control in a palliative sense. And therefore, if there are any side effects that are troubling her and are impacting her quality of life, we have a very low threshold to change the treatment. With neuropathy, once it starts, if you don't do something to try and combat it, it will only get worse. So for that reason, because vincristine is renowned to be neurotoxic and it tells you this in the resource pack, what we need to do is minimise the chances of this causing further neuropathy. And the only way that we can do that really is either take the drug out completely or dose reduce. What we would typically do on the basis that it's reasonably early stage neurotoxicity, there's still a chance that we can manage it and keep the vincristine in the protocol, we would follow the guidelines which state that it is interfering with function, because it is, and we would drop the vincristine dose to 75% as outlined in the regimen. Okay, so moving on to question 6, what are the management options if her symptoms progress any further? The answer to this is basically based on the analgesic ladder. So that's referred to in the lecture slide. We would manage it exactly the same way as any other type of pain, but what we are being mindful of is that this is a neuropathic pain. We're likely to add in an adjuvant, for example, gabapentin or something that is particularly useful in a neuropathic sense, but we would still start at the bottom of the pain ladder like for any other pain management. The thing to mention, as you probably are already aware, we need to be very, very careful with paracetamol in chemotherapy patients, because paracetamol is brilliant as a pain relief, but it also helps reduce the temperature. If we mask a spike in temperature, the result of an infection in a chemotherapy patient, that could delay them getting help for what could be quite a severe infection. So paracetamol we use with a great amount of care in chemotherapy patients. So moving on very, very quickly to number 7. If Miss Elsie was taking a higher dose of cyclophosphamide, she may be given some hemostics, and what are they and why does she need them? What would additional supportive treatment be required if there was a positive result? So hemostics are used for urine analysis, and they test for blood in the urine. This is all of, if you Google hemostics, you'll find this information fairly readily. They are also referred to in the chemotherapy guidelines. So if you remember back to the lecture, we talked about hemorrhagic cystitis. Cyclophosphamide is renowned to cause that at certain doses. In this case, what we're doing, we're testing for the possibility of hemorrhagic cystitis by detecting blood in the urine. If there was blood in the urine, that would be the cause, the cyclophosphamide, and we would most likely need to give this lady some Mesna. You'll remember Mesna protects the bladder because when cyclophosphamide is broken down, one of the metabolites is a product called acrolein, and acrolein can irritate the lining of the bladder, which in turn causes the hemorrhagic cystitis. The Mesna binds the acrolein in the kidney and it renders it useless, thereby preventing hemorrhagic cystitis. The key thing, as well as Mesna, if we do see blood in the urine, we would try to keep the cyclophosphamide dose the same. Mesna is very effective. We should manage to do that. They need to drink plenty as well, just to make sure that we're flushing the cyclophosphamide sufficiently through the system. So that brings me to the end of case study 2. Apologies, my slide just stopped moving, so I will stop my share at the moment. I would share my slide, but my PowerPoint appears to have crashed, so I can't actually move between the slides at the moment. They are just a replica of the questions as they are in the workbook. There's no additional information on there for the moment. I will try and go back up to go through the last part after the case study. So case study 3 is a stage 3 colorectal cancer patient who is now prescribed capecitabine as monotherapy. The first question asks, based on her body surface area of 1.64 meters squared, how many tablets and of which strength would you supply for 14 days of treatment? So for capecitabine monotherapy in colorectal cancer, we would typically use 1,250 milligrams per meter squared orally twice a day. For a BSA of 1.64, that means that her dose would be rounded to 2,000 milligrams twice a day. So that means per dose, she would need 4 500 milligram tablets twice a day. So that means she would need 8 500 milligram tablets per day. It is a 14-day treatment. You're given that in the question. So for 14 days, she would need 112 500 milligram tablets. If anyone had any questions on that, please let me know in the chat. Otherwise, for the moment, I will move on to the next question. So you then asked, why is loperamide usually prescribed for patients on capecitabine, and why is it important that they take it when needed? You'll know, hopefully from the lecture and from the SBC as well, that diarrhoea is a dose-limiting toxicity of capecitabine. So if we do have a patient who has diarrhoea, then particularly if they've got severe diarrhoea, they need to be carefully monitored and given fluid and electrolyte replacement if they become dehydrated. We can give loperamide if needed. If we have a patient who is getting grade 3 or 4 diarrhoea, there's actually quite a lot of support that's required. Once we get to that point, we typically have to dose reduce the capecitabine. So it's really important that we firstly know to what extent a patient is having diarrhoea and we manage it as best as we can. So it's important not only to think about it from the perspective that they have diarrhoea and to control that aspect, but also think about dehydration and fluid replacement, electrolyte replacement if needed. This is all covered in the lecture slide. You're also given a link to guidelines on management of diarrhoea in chemotherapy patients on that slide. So moving on to question 3. 3 months into her treatment, she reports she's feeling very anxious, worried about what the future might bring. She's very tearful, finding it difficult getting to sleep, even though she feels very tired. She confirmed that she's losing weight, as she often doesn't feel like eating and keeps snapping at her family when they try to help. So you ask what you think she may be suffering from and what the treatment options are. The first is, it sounds like it's depression and or anxiety. So what we would first of all make sure is that she speaks to her oncologist, and hopefully will also speak to her GP as well. They could refer her for CBT, and CBT has become increasingly popular, particularly in cancer patients on treatment, because if we can successfully support somebody with such symptoms with CBT, we avoid needing to give another drug or another medicine on top of everything else they may be receiving as part of their treatment. So from an interaction perspective, we would try, if we can, to find supportive measures that are not pharmacological before we go down the route of offering pharmacological support. It may be, however, that antidepressants or anxiolytics, which would be based on your standard depression protocols, that we follow NICE guidance for depression. There's no reason to differ just because it's a cancer patient, but we would aim to look for an opportunity to use CBT before we went down the pharmacological route. So that brings me to the end of the case study. Has anybody got any questions on those parts? Okay, I am going to attempt to fix my PowerPoint. Bear with me as I was restarting it while we were going a sample exam question. They are to be completed in your own time. After this workshop, I will give you the answers to the 4th case study the week commencing the 8th of March. The reason for it being that little bit later is the last iteration of this workshop doesn't run until Thursday afternoon. I then won't be back at work till next Tuesday. So the sample exam question, however, is for your information. I will not be releasing the answers for the exam question. So just bear with me a moment. I've just realised I've lost the chat, so I just want to make sure that nobody is trying to ask me any questions. Just bear with me a second. Okay, so there will be no answers released for the exam question, but you will receive the answers to the case study the week commencing the 8th of March. So very quickly, before I go through the update to the lecture, just to reiterate the learning outcomes for this particular workshop, just bear with me a moment. I'm just going to stop sharing my screen because it's just... Okay, sorry, I'm just going to go through the chat. I've had a chat question which I couldn't see because my PowerPoint overrode it. You can attempt the exam question. I have been asked not to provide any feedback for it. It's purely for your own information to give you an example of what sort of questions you may be tested on in the exam, but I have been asked not to provide feedback on the question itself. Okay? So I'm now just going to go, apologies, I'm having some slight PowerPoint issues this morning. Bear with me a moment because my slide which has got the update of the guideline has frozen. So just bear with me a moment. If anyone have any questions, if you can pop them on the chat for the time being. That would be brilliant. Thank you, Tiffany. Apologies to anyone else who put your thumbs up, but at the moment I can't see that many people. Thank you very much to all of those who have responded. So just to explain the reason for putting this up. So in the lecture, at the end of the slides, there was a section that had the references, which basically gave you the information on where I had got my detail from, particularly with respect to the chemotherapy side effects. What unfortunately happened is the lovely people at London Cancer have updated their website. So at the end of the lecture, there was a group of protocol where I had put, if you need any information on the side effects of chemotherapy and their management, please go to the expert reference group chemotherapy guidelines as part of London Cancer. That whole folder had unfortunately been taken down. So on this slide, I have got, and this slide will get posted on Moodle, don't worry. This is a link to where I would advise you find information. Now, the one that seems to be the most tricky to locate now is the antiemetic guideline. So the ones that are referred to in the lecture are unfortunately no longer available. So on this slide, you have two separate websites. The first one is a link to the Thames Valley Cancer Network antiemetic policy, which the table on the slide has been taken from. And this is where I would suggest you refer to for antiemetic information with respect to chemotherapy. It's a very extensive guideline. This table is one part of a number of pages that they have published there. Now, one thing I just wanted to warn you, there is a slight difference in the terminology in this guideline compared to what I used in the lecture. So traditionally, we classify the emetogenic risk of drugs based on low, moderate, high, and very high. In this guideline, you'll see they haven't actually distinguished between what we would refer to as high risk at the bottom of this table in the old guideline, and what would have been boxed in red would have been referred to as very high risk. What they've done is they called both of them high risk, but one is with a prepitant and one is without. In the slides referred to within the lecture, anything that involves a prepitant is very high risk. And this bottom part, which refers to high risk, is just high risk. So what I just wanted to make it clear to you is that when I talk about very high risk in the lecture, I'm talking about the top half of this table, which is a high risk regimen with a prepitant. So I hope that makes sense. With respect to what you need to know about antiemetics in chemotherapy, this is something that's come up a few times since the lecture. You need to understand the emetogenic risk, how we work it out, be able to describe the management options. So as I said, there is a slight variation between trusts. What I'm looking for is if I ask a question, and for example, I think there is actually one antiemetic question in the sample exam paper, is a sensible or should I say a regimen I know exists in practice. I have worked in multiple trusts as a cancer pharmacist. No two trusts have had exactly the same emetogenic treatment regimen. I'm looking for a sensible answer. So my advice to you is the doses and the frequency may vary slightly, but broadly the overall daily dose and duration of treatment is the same. And to give you an example of this, if you look at the regimen that I've just put up on the screen here, if you look at what we would call very high risk, which is the top part, it refers to the dexamethasone dose as 8 milligrams in the morning for 2 to 3 days after chemotherapy. That is 8 milligrams a day. That is exactly the same as 4 milligrams twice a day. In my mind, either of those would be correct. So that's just an example of the sort of thing I mean. The other thing to mention is that they also have dopamine antagonists at slightly different doses than what I gave you in the lecture. This is because this particular guideline is very, very strictly following MHRA guideline with respect to preventing the cardiotoxicity that we know is linked to dopamine antagonists. Not every trust adopts that policy in full, particularly when it's a palliative patient. So I will not, in this respect, as long as you give me a sensible dose of domperidone or metoclopramide that is one that is found in a guideline, it is not going to be marked down if it's not absolutely perfectly what is in this one, if I know that in practice we would use it at that dose. So I hope that makes sense to you, because if you look on the internet, you will find different policies are different. So there is a small degree of variation. I try to find a news source which is as close to what I use in the lecture as possible. The next thing just to mention is you do also have a second website. Apologies, I can't see the chat at the moment. I will come to it in a second once I stop sharing. There are what's called cancer topics. And if you look under the chemotherapy folder, which is what the second link takes you to, there are lots of other pieces of information in there, and it links to additional guidelines. So I'm just going to very quickly go over the learning outcomes. So this is exactly what I said at the beginning. So hopefully you've had an understanding of how we use those calculations, and we've talked a bit about blood tests. That particularly will be relevant if you attempt the exam question. You should be able to recognise common toxicities and side effects. We will, if you do the exam question, be looking at mechanisms of action of the chemotherapy drugs by 11. We've looked at monitoring parameters and understanding and recommending toxicity management, but also hopefully you've had a chance to practice using appropriate resources to help you make decisions around cancer treatment. So that brings me to the end of my slide. I just wanted to say, if you have any questions at all, please don't hesitate to contact me. Just a little reminder that my working days are only Tuesday to Thursday. So if I receive emails outside those days, it will take until my next day in office or day at work for me to pick up that query. But please do email me if you have any questions.